Bismillah ar-Rahman ar-Rahim. My name is Abid Alwan. I am intensivist in Prince Sultan Medical Military City in Riyadh. We'll talk about general ICU care. This is big lecture. We'll try to concentrate on topic that can improve mortality and morbidity in the ICU and see the evidence behind it. Let's start with the prophylaxis against thromboembolism. In this study, which was published in 2017, they found that only 40.9% of the patients they are receiving the appropriate prophylaxis doses. And in this study also, they found if we will give the appropriate thromboprophylaxis, we can decrease the death risk, absolute risk by 4.1%. Unplanned extubation. So either it will be by the patient himself or during nursing care. If this extubation will be failed, then the mortality will increase. And also the possibility to discharge the patient to chronic care will be high also. So in this study, which was published in Egypt last year, they looked for the risk factor for unplanned extubation. They found that physical restraint, agitation, less sedation, lower Ramsey score, unsatisfied nurses and physicians, all of these things is risk factor for unplanned extubation. In this study from the American Journal of Respiratory and Critical Care of Medicine, they found that the patient with unplanned extubation, they have significantly longer duration on mechanical ventilator, longer ICU stay, and longer hospital stay. So let's move to the low tidal volume ventilation in ARDS. This is the famous study in New England Journal of Medicine. They found that if we will use 6 ml per kilogram tidal volume, then the mortality will decrease from 40% to 31%. Early recognition and treatment of sepsis. So with the new definition in 2016 for the sepsis, which is sepsis 3, now sepsis is defined as life-threatening organ dysfunction caused by dysregulated host response to infection. And how we can identify the organ dysfunction? We can use either SOFA or quick SOFA. By quick SOFA, we need 2 of these 3, either altermentation or respiratory rate more than or equal to 22 breaths per minute, or systolic blood pressure less than or equal to 100. If we will use the SOFA, we need also 2 points. We will look to the respiration. We'll see the PF ratio, and according to the result of the PF ratio, we can give the points. For the coagulation, we need to check the platelet. For the liver, we'll check the bilirubin. We will check the MAP or if the patient is receiving vasopressors. We need to check the GCS. We need to check also the creatinine or the urine output. So early recognition and treatment of sepsis, this is the famous study in 2006 by Kumar, where he found that for each 1 hour delay in giving the antibiotic for the patient with sepsis, it will be associated with decreased survival for almost 7.6%. This is another new study in 2019. They found that for every delay in giving the antibiotic for sepsis patient, after the doctor write the order more than 1 hour, which is 1 to 6 hours, it will increase the odds ratio to 1.3. So what about the sedationification? In this study, they are stopping the sedation daily till the patient wake up. And they found that for the patient with sedationification, the median duration for the mechanical ventilation was decreased from 7.3 days to 4.9 days with significant p-value, and the length of stay was decreased from 10 days to 6.4 days. For the central line associated bloodstream infection, the morbidity and mortality was associated with this infection. They found that for the patient with CLABSI, the mortality rate will increase significantly from 18.7 to 28.1. And the median stay in the ICU was longer by 13 days. So this big study with a total of 108 ICU with 375,000 catheter days, they applied the CLABSI bundle, and they found that the reduction in the CLABSI was up to 66%. This is the CLABSI bundle, which including hand washing, using of full barrier precautions during the insertion of the central venous catheter, cleaning the skin with the chlorhexidine, avoiding the femoral side if possible, and removing unnecessary catheter. This is an example for the checklist you can use for the insertion of the central line by the CDC. For the catheter-associated urinary tract infection, it has significant increase in the mortality and long length of stay in the intensive care unit and in the hospital, according to this study, which was published in 2011. So how we can prevent it? In this study, they applied bundle, which is containing reducing the catheter placement. So only the patient who's in need will have the Foley's catheter. They will have protocol for the insertion, including aseptic technique and appropriate maintenance of the catheter. So they will have daily cleaning of the catheter, washing hands, keep the bag away from the ground, and earliest possible catheter removal. And they found that by applying this bundle, they have decreased the COTI from 2.4% to 0.7%. In this study, they found that if they will apply a reminder system for the need of the Foley's catheter, they can improve the COTI dramatically. Feeding in ICU, it's very important. In this study, they found that if we can give feeding for a mechanically ventilated patient within 48 hours, we can improve the ICU and hospital mortality. This is another study in 2019. They found in this study that if the patient is receiving more than 90% of the protein requirement, then the extubation rate will be higher, significantly more than the patient who is receiving less than 80% of the protein requirement. So now, are we delivering the right care at the right moment in a safe way? We need to know this by comparing our ICU with the standard recommendation and with the other ICU. For example, we can check the ICU readmission rate within 48 hours of the ICU discharge. So, if the patient will be readmitted to the ICU, his mortality rate will be higher. Standard mortality ratio, which is the ratio between the observed number of deaths in a study population and the number of deaths would be expected, which was recommended to be done by the Critical Care Congress in 2012. And this is our SMR in in the ICU in Prince Sultan Medical Military City. We can see that this is the benchmarks and this is our average. We are below the benchmarks. Thank you.